Relieving orthopedic injury pain. Pain is a complicated thing for many of our patients, so it's something that we have to discuss. Oftentimes, you will hear coaches ask if the distress is a result from torn tissues or simply in the athlete's head. Is there a pain or is there truly injury? Torn tissues could be aggravated if an athlete continues to practice. Torn tissues could be aggravated if a patient continues to practice or engage in activities that resulted in the original injury. If pain is only in the athlete or patient's head, then the athlete or patient may be able to suck it up or gut it out. So, how should you attend to their pain? Or do we encourage the individual to return to practice or other activity? At this point, as a clinician, we may have to make a decision to remove somebody from participation or return them to their activity. So, how do we decide what to do? The principles of pain relief. There are drugs, psychological techniques, surgical procedures, and physical therapy techniques that may result in varying degrees of success for pain relief. There is no one method that is consistently successful. Each individual responds differently, probably because pain is multidimensional and we cannot concentrate on a single aspect of pain. Successful clinicians are directed by a core philosophy that are defined by principles. The principles are more important than specific tools, and thus, therapy becomes an art. We really have to cater this to our individual patients' needs, preferences, and desires. In order to address pain, we need to make the patient the owner of their pain. We must have a thorough evaluation and a clinical diagnosis that addresses exactly what is going on. We need to discuss the diagnosis and plan a treatment together with the patient. It may also be helpful to include significant others or family and friends in this conversation. The patient must understand the injury, talking about the pathomechanics and even the outcome of the injury. And then they have to agree to comply with the treatment approach. We also need to establish goals in consultation with the patient. This must be our physical goals with specific, quantifiable ways of identifying and measuring progress for each goal. This could also include social and work goals as well. We must remember that pain is multidimensional. It has a multidimensional response to multidimensional stimuli, and both of these may change over time. Both the stimuli and the response include social, emotional, and psychological components that often morph over time. It is important to remember that the pain response intensity and duration do not always correlate back to the initial stimulus. The principles of pain relief. Is someone injured or hurt? Do we ignore or do we listen to the pain? Do we ignore the pain or do we listen to the pain? This can be difficult to determine. Athletic success often requires sacrifice. Athletes frequently must ignore discomfort and some types of pain in order to participate. They must be able to push through difficult challenges, push beyond their previous best effort, and persist in spite of pain, especially during conditioning. But injury pain often causes neural inhibition that decreases the neuromuscular functioning, including range of motion, strength, agility, and other factors. Persistent painful activity enhances this neural inhibition, and it may result in a permanent physiological block for the individual. Therefore, ignoring this type of pain is detrimental to the patient and their recovery. As a practicing clinician, we often have to wear different hats, including being a demanding disciplinarian or even a benevolent benefactor. There are times when we need to act as that demanding disciplinarian and act as a playback for pushing the body beyond its limits. But we also must understand that benevolent benefactor. We need to have a protective mechanism to keep the individual from causing further damage. So it's important that we wear both of these hats. The body often mishandles pain. There is great memory for what it wants to do, but not why it is doing it, and pain often persists long after the cause of the pain has been resolved. Pain must be respected, and we can use it as a guide. But as a clinician, we also need to be tough on the pain when necessary so that it does not take on a life of its own. So, how do we feel about the phrase, no pain, no gain? During conditioning, this phrase is okay. However, during rehabilitation, this is a no. We need to use the pain as our guide. By ignoring the pain, it equals no brain. But pandering to the pain can propagate pain. So these are important concepts to remember. One of the first steps to addressing pain during rehabilitation is resetting the central control during rehabilitation. It is not just enough to get rid of the pain sensation, but we also must get rid of the effects of the pain. That is a reset to the system or a reset of the central control. For example, there is a Chicago plane analogy. A tire blowout occurs during takeoff for the airplane. This shuts the runway down so that the damaged plane and debris can be removed. The runway may reopen after about 6 hours after the pain has been removed. However, thousands of passengers are stranded because of the canceled flight, both to Chicago and elsewhere. Meetings and business activities must be rescheduled. Hotel reservations and leisure activities and vacations all must be changed. While it seems minor to have a blown out tire, it may take months to fix the effects of the blown out tire. This is the example of resetting the central control. We can do this through guided exercises and specific activities aimed at resetting the central control during the rehabilitation process. There are different sources of athletic injury pain, including nociceptor pain, neuropathic pain, learned pain, and idiopathic pain. Nociceptor pain causes most sports injury pain. Nociceptors are stimulated by injured tissues. These injured tissues have mediator releases. It can also be stimulated by edema pressure, stretching injured tissues, or an otherwise normal activity in a tissue that is sensitized from disuse after injury. Neuropathic pain. This is a complex, chronic pain state that is accompanied by tissue damage to nerve fibers. The nerve fibers become dysfunctional. The incorrect signals are sent to the brain and other pain centers in the body. And this pain often shows up in illogical ways. This occurs due to acute nerve damage in which the nerve is crushed, compressed, stretched, or even severed. This may include things like stingers or pinched nerves. This may also occur in otherwise normal activity in a tissue that becomes sensitized from disuse following injury. Surgery that involves neural tissue, such as an amputation or phantom limb pain, and conditions that cause nerves to become dysfunctional, such as alcoholism, chemotherapy, nutritional deficiencies, or even diabetes. Learned pain, learned or conditioned response, develops from a patient's pain memories of a physiological or emotional elements of pain experiences. The painful stimuli is indirectly paired with any of an infinite number of environmental or sociological stimuli, even inactivity. And eventually, these secondary stimuli start to elicit pain in the patient. Finally, there is idiopathic pain, and this is pain of an unknown origin. There is no identifiable pathology. These are frustrating for clinicians, so it is important that you do not lose your mind trying to locate a cause, because often it can be very difficult or even impossible to locate one. Placebos and pain relief. A placebo is the Latin for I shall please. A placebo is a medically inactive substance that is given for its suggestive effect. This is done to satisfy a patient's demand for medicine, often as a mock intervention, frequently called a sugar pill. In these cases, the patient thinks that they actually receive medicine. The psychological effects of the patient's expectation is responsible for the results. This has a powerful influence on therapeutic interventions. But there is a lot of quackery or even snake oil that abounds in physical medicine. Snake oil salesmen often dupe the gullible into thinking that they have powerful medicine. Half of the strength of the true procedure is in double-blind studies. For example, placebo treatments have been used in postoperative pain, diabetes, and chronic headache patients. These studies found that relief happened to 35% of all people with placebo treatment as opposed to actual medicinal treatment. In ulcer patients in one study, 76% obtained relief with Tagamet, while 63% obtained relief from a placebo treatment. The Tagamet is the medicine, and the placebo is the sugar pill. We need to remember back to our ethics lecture. It is important that our patients are able to trust us and that we are not deceiving our patients. Do not use unproven treatments on gullible patients. Maximize proven treatments on believing patients. When clinicians and patients believe in a specific treatment, there is a high probability of a successful outcome. The placebo effect may enhance a modality effect. Some techniques that may enhance our placebo effect is to educate the patient about the modality intervention, be positive, and set reachable goals for our patient. It is important that we use a variety of intervention techniques. Our patients frequently respond to different injuries in various ways. Patients also respond differently than other patients with the same type of injury. Unfortunately, with our therapeutic interventions, the body sometimes adapts to the treatment methods, rendering that method ineffective. So we must be able to change methods as necessary. Direct versus indirect pain relief. Indirect, we get rid of the painful source, such as the swelling. In a direct pain relief, we deal with the pain itself. We may utilize TENS or transcutaneous electrical nerve stimulation to utilize the gate control theory for pain or even release opioids to manage the patient's pain. There are many different tools that we can utilize to decrease a patient's perception of pain. These may include immobilization, therapeutic exercise, counter irritants, thermotherapy, electrical therapy, cryotherapy, and even psychological tools. We will discuss each of these in a little bit more depth. Immobilization is especially useful in early stages of rehabilitation. This allows irritated tissues to quiet down. However, prolonged inactivity is dangerous and may result in prolonged disability. We need to transition our patients to controlled activity as soon as physically possible, but managing this process is an art. It's not a perfect science. Therapeutic exercise. Low-leveled, controlled therapeutic exercise decreases edema, inducing pain by stimulating the lymphatic flow. This results in a reducing mechanical pressure on nociceptors. Isometric contractions, interspersed with static stretching, help to relieve pain by reducing muscle spasms. This can be utilized in a therapy called cryostretch. Therapeutic exercise should be relatively pain-free. Mild discomfort or even stretching is okay, but serious discomfort must be avoided at all costs. Counter-irritants are substances that irritate the skin, thus closing the gate on mild pain. This causes the brain to switch its attention from the pain to the counter-irritant, often on the skin. This is one of the oldest and the simplest pain relief methods. Some examples of counter-irritants include ethyl chloride spray, ice packs, vibration therapy, tactical stimulation or pressure therapy, and analgesic balms. Thermotherapy is effective for reducing general aches and pains. Thermotherapy can be effective for dull pain that is common the day following extreme exertion, and it also can help to treat chronic pain, but it is typically not used for acute pain. Electrical therapy reduces muscle spasms, releases endogenous opioids at pain receptor sites, and stimulates non-painful nerves to gate the pain. Cryotherapy reduces pain to allow for early exercise. In joint sprains, particularly ankle sprains, a therapy called cryokinetics is extremely effective. For muscle spasms, cryostretch has been extremely effective as well. Cryotherapy is often used to treat acute pain. Cryotherapy is often utilized to control post-operative pain and has been discovered that patients use less medication following operative procedures when cryotherapy is employed. Cryotherapy immersion is better than massage as there is less tissue warming with the immersion. Psychological tools. This includes our goals and expectations, the use of biofeedback, and cognitive strategies, including attention modulation, meditation, use of a positive attitude, and social interaction. Many psychological behaviors modulate perception or interpretation of the sense or situations. This influences manifestation and the treatments of pain. The sight of blood may exacerbate pain from a simple wound. Learned pain is a psychological behavior that has gone astray. Placebo effects can become very powerful, either positive or negative in their situation. Monitoring and assessing pain relief during rehabilitation. This helps us to gauge our activity level. Pain during activity indicates that the activity is too strenuous or complex. Residual pain or pain the following day indicates that the previous day's activity was too strenuous. Both situations may induce neural inhibition and thus hinder the rehabilitation process. Pain and pain relief are difficult to measure. Pain tolerance varies greatly between individuals, and pain perception is extremely subjective. The best assessment tools attempt to quantify one's subjective interpretation of their pain. We frequently use questionnaires or scales to monitor this. Most questionnaires or scales measure a single quality of pain. However, the McGill Pain Questionnaire is the exception, as it measures 4 qualities of pain. Some common pain instruments. The number scale measures pain intensity. There is a range of numbers, for example, 1 to 10. The descriptors may be associated with some or all of the numbers, and a patient selects the number that best describes their pain. The verbal rating scale is a group of descriptors with no numbers, such as absent, mild, moderate, or severe pain. This is thought to be too insensitive to slight changes to be utilized clinically, so often it is not utilized in the professional setting. The visual analog scale is a line with specific length, usually 10 centimeters. This has contrasting descriptors on either end, such as no pain and unbearable pain, annoying and severe, or dull and sharp. There are no numbers on this scale. The patient marks where they feel their pain is. We measure from the left side of the scale to the slash or where the patient has marked to determine the measure of pain. This scale can give a pseudo percentage. This scale is robust, sensitive, and reproducible, and may also allow patients to see their previous results. The graphic rating scale is a horizontal line similar to the visual analog scale. There are anchor points at each end, and descriptors spread along the line. We administer and score it the same as the visual analog scale. Some individuals feel it is a better scale than the visual analog scale because it is more sensitive to the intensity and has greater within and between subject reliability. Finally, the McGill Pain Questionnaire. This is the most complex scale. This uses pictures, scales, and words to measure four qualities of pain, including sensory, affective, evaluative or magnitude, and miscellaneous. This also includes location and changes in pain. There are three parts to the McGill Pain Questionnaire. Part 1, where is your pain? The patient will circle on the picture where the area of greatest pain is for them at that moment. Part 2 is the qualities of pain. And part 3 is the change in pain.